asking me to present endometrial receptivity assays in clinical practice. What have we learned? My presentation could last 1 minute because the answer is very little. We learned very little from the clinical point of view, but I'd like to share with you the way in which we reached the point to understand a little bit more. I know that you have had a beautiful lecture by Linda, so I will be more focused on endometrial receptivity assays, and then I will explain why I am not sure that we learned enough. To talk about endometrial receptivity, we need at least to understand 2 or 3 points. One, on human physiology of implantation. I'm sure that the majority of you are very well aware about this, but let me share with you some pieces of information that maybe are not totally clear to all of us. If you look at this paper, that as you see is an old paper, I think is really very interesting. What has been done, 121 healthy women attempting to conceive in 707 cycles. At that time, the only instrument that they had was a daily urinary level of ACG to understand if a conception, a natural conception of course, occurred. What is the result? Out of these 221, 23 women had no ACG increase in those their attempts. 198 had an increased level of ACG, again measured in the urines. What happened to these 198 women? 43, that means 22%, had no gestational sacs, 19 had miscarriages, and 136 had clinical pregnancies. What does this mean? Well, 2 things. One is that the preclinical losses, in fact, include 30% of the people, of the patients that were involved in this attempt. But the remaining 70%, of course, they were fertile women, they did conceive. So there is a notable proportion of embryos that never implant, and many that do are lost without clinical recognition of pregnancy. And to me, this makes human reproduction very peculiar compared to the other mammals. The point I also like to make with this slide is that, in fact, if you look at the point of implantation, it is extremely small compared to the huge amount of endometrium. So again, to talk about endometrial receptivity is a little bit strange when you look at the fact that everything happens only with few cells around. So for implantation to occur, we know this. We need a competent embryo, and we are not going to talk about this today, but it has to attach to a receptive endometrial line and to make the thing happen properly. The mechanism is complex, and the reason why in only this slide in 2 minutes I want to review with you is only to then to make you aware of the fact that any receptivity test is a test that undergoes through a series of difficulties because we have multiple paracrine and outcrine inputs that drive the tubulization of the endometrium in a conception cycle. Because once that the mechanism is initiated, the decidual process is constantly evolving in transit from an acute or into an initiation phenotype. And as soon as this is finished, we have an anti-inflammatory and hyper-secretory phenotype. So 2 completely different stages in few hours actually will happen, on at least maximum 1 day. And once the inflammatory secretome and the visualization of stromal cells coincides with the window of receptivity, then we have the start of the communication with the implanting embryos. So, if the embryo is successful in implantation, it's okay. Otherwise, there will be an implantation failure with the embryo beneath. So the model, and you were mentioning this before in the question, of the repeated implantation failure is an interesting model because at least we can know or we can study looking and watching at this mechanism almost from live during our IVF treatments. I want just to point the attention on the definition of RAF because actually everything started, I don't want to say 30 years ago, but at least in the literature, this is what we found. I thought there was something before, but I didn't see. But at that time, for us, with the success rate of IVF, we were thinking about repeating hepatic failures in patients younger than 38 years with 2 or more previous implantation failures with normal cardiac. Few years later, Cornell adjusted the definition, absence of gestational cycle ultrasound at 5 or more weeks after 3 embryo transfer with high quality embryos or after the transfer of more than 10 embryos in multiple transfer. Again, 7 years later, Cornell, another definition by Carlos, failure of implantation in at least 3 consecutive IVF attempts in which 1 or 2 embryos of high grade quality are transferred. And then, few years later again, we had the failure of clinical pregnancy after transfer of at least 4 good quality embryos in a minimum of 3 threshold frozen cycles in a woman under the age of 40. So, you understand that even looking through the literature is not easy to understand what is a repeated IVF failure. That leads to the concept that in fact we have a heterogeneous population with two-way interaction. On one side, we have a uterus in which, if we really want to study repeated IVF failure, we have to exclude uterine abnormalities, coagulation defects, endometrial anomalies, and immunological reaction. On the other one, that is the other part of the coin, we must have a viable embryo, and by the way, using as a model IVF and dating techniques, we also have to exclude any bias related to in vitro culture condition and also the mechanical surgical procedure of the embryo transfer. So, in other words, if we concentrate on the capability to find an assay able to tell us something about the window of the implantation, we are really most probably fishing in the ocean. The paper that has been published in Nature Medicine regarding the regulation of the genes implicated in the window of implantation is quite interesting because it shows to you that when we look at the period of the cycle, menstrual, early, late, proliferative, and early secretories, you see how all these genes are expressed in a completely different way according to the time in which they are checked. And when you go to the early mid secretory phase, in this phase, you really see that this corresponds or should correspond to the so-called window of implantation. So, if we want to get information from the expression of genes, we need to look to some specific genes. And that's the reason why when the first information came out with the so-called ERA test, they found out that 1 patient out of 3 had a pre-receptive or post-receptive status of the endometrial. And that was in patients with repeated implantation failure. So that was the model. And in fact, when you look at the 2 groups, the so-called RAF and the control group, you see that there is a huge difference in terms of receptive and non-receptive group. When you look at the prospective interventional multi-center trial, and you look only to patients that have failed more than once an implantation, then you reach the point that in fact these 25 patients, in fact, if they had the so-called personalized and the transfer point of time, they resulted in a very high pregnancy rate And this was due to the fact that the implantation rate was also high, about 38%. In this group of patients who failed in the same laboratory different attempts. These data, of course, were in one way or another found, or it was not easy to replicate this data. So here you have the list of the authors that at that time believed that the ERA test, the name of the test we heard about, not appear to be clinically useful for patients with risk, but in fact, when you remove the problem of the euploidy or aneuploidy, so you remove, at least of what we know, the uterine factor, you see that there is a difference in terms of implantation in those embryos that do implant when you transfer them at the right time, so at the right time. Luckily, in this study, there was no significance or no statistical significance, maybe due also to the limited number of observations that have been done. But again, there was a piece of information that could make us thinking that maybe the ERA test done by microarray could be not specific enough, and maybe the use of NGS could help us to understand a little bit more. So that's the reason why we moved from microarray, the ERA test, to another test that used NGS. The use of NGS has an advantage, apparently, because the meta-signature of human endometrial receptivity, it goes to a meta-analysis and a validation study of the transcriptomic biomarkers. So actually what we have is the same concept that ERA, but all concentrated in 67 selected genes, and the accuracy can go down to a single molecule. And by the way, you reduce dramatically the costs of this test. And you can also modulate. Instead of having receptive, non-receptive, you can have a sort of receptomics. Let me give you an example. For instance, if you consider receptive between this value and this value, you can have a receptor that is early receptive. So that means that embryo transfer should be done even 6 or 12 or 18 hours later. And on the other hand, if you have a completely or perfectly receptive, you don't have to move your transfer. On the other way, if you have a post-receptive endometrium, again, you can anticipate of 12 or 24 hours according to where your receptor is telling you where at the time the endometrium is. We can argue, of course, that the months after maybe it's not the same as the months in which the test is done. But repeating the test 2 months, one after the other, actually gives, at least in our hands, roughly the same result. So, at the end, you can add that using these biomarkers, you have a conception of pre-receptive, of receptors and post-receptives due to the expression of these genes that I was mentioning to you. So, the effectiveness of personalized and transfer guided, and now I go back to the microarray test, to the ERA test, because we don't have up to now published a large number of patients or a large trial with NGS. But anyway, if you look at this patient, 458 patients, young patients, in which IVF was done and then blastocyst transfer has been done, and we look at the intention to treat in personalized embryo transfer, frozen embryo transfer, and fresh embryo transfer, you see that there is a difference in terms of cumulative pregnancy rate, is an advantage for those patients in which embryo transfer has been done after the adjustment by the ERA test. And since in this study, as you can imagine, you could also have quite a large profile. If you look at the numbers and the figures instead of intention to treat, but you make an analysis for protocol analysis, again you see that the percentage of the implantation rate changed quite in a dramatic way, and in doing so brings back a higher chance of having a cumulative not only pregnancy rate but also cumulative live birth rate, suggesting that maybe also the beginning of implantation, what we usually call biochemical pregnancies or early miscarriage, could also be reduced once at the right time of transfer is scheduled. Want to finish my presentation showing you on clinical practice actually what happened in a clinic. These are our data. So there are 85 repeated IVF failure patients. 68 patients used microarray, whilst 47 had NGS test. The standard protocol for HRT in our clinic is estradiol valerate, starting with 4 milligrams and then going to 6 milligrams and keep going the same after 5 days from the beginning. Having only one ultrasound at day 11 to measure the thickness of the endometrium, and then adding progesterone starting from day 14. And scheduling the test, the ERA test, or the BRAD test, the day 19, expecting to be the day of the blastocyst formation. And once that the test is giving us normal results, again, the month after doing the first transfer. Otherwise, postponing the transfer without changing the treatment or anticipating the transfer, again, without changing the treatment according to the result of the two tests. So, 85 endometrial receptivity test, when we use microarray, you see that we have 58 receptive endometrium, and in these selected categories of repeated IVF failure patients, you see that the remaining 40% was pre-receptive or post-receptive. When we use the NGS group, as you can see, in fact, we had half of these patients had pre-receptive endometrium. That means that they were not exposed enough to the amount of progesterone that we were giving without changing, of course, the dosage and the protocol. So that during the test day 19, this is what we found. When we look at the clinical pregnancy rate and the clinical pregnancy per patients using the two tests, you see that the white column is the result of the clinical pregnancy once that the test has been, according to the test, the endometrial treatment has been adjusted according, as I mentioned to you, to the concept of pre or post receipt. And this is the same result when you look at the clinical pregnancy rate per patient, so the cumulative one. Again, as you have seen, the numbers are not very big, so we have to take this data with a little bit of suspicions, but I think it is important to have a look to this interim analysis. You see here when we split the embryo transfer done by using the microarray group, so the ER test, or the NGS group, so the other test. And again, you see that there is no difference when you use ER test once that you adjust the day of the time of transfer according to the ER test. We haven't seen a difference compared to the previous test. But when you look at the NGS, here you see a difference. So when you adjust according to NGS your time of transfer, then you have higher incidence of clinical pregnancy. Looks like, in other words, this test seems to be more appropriate or has different sensitivity compared to the macro rate. When we split the macro rate group and the NGS group in terms of patients, so not in terms of endo transfer, again, most probably due to the limited number, you see that in the macro rate group there is no difference, so it doesn't make actually difference in adjusting time of transfer. When you use NGS, there is quite an important difference, even if the number are not giving us the full statistical significance from here. So again, look at this data with a little bit of suspicion, but you see the trend and you see the difference between the two tests. What is interesting is that when you compare the two groups and you split the NGS with patients that are receptive or pre or post receptive that did not do PGT for aneuploidy, and those that did PGT for aneuploidy, so in which the so-called embryo factor has been in bracket removed, so at least we know that there are diploid embryos, again you see the difference. So I wanted to show you this data, even if they are preliminary data, just to conclude saying that most probably, if you want to use the specific test for endometrial receptivity in terms of window of implantation, maybe we should not use this test for all our patients, but we should stratify the subgroup and choose those patients that really demonstrate not to be able to have an implantation. And secondly, most probably we should move out from microarray and using a test in which NGS is probably more sensitive for this sort of test. So I'd like to finish here, and of course, I'm more than happy if there are questions to share these questions or to accept your questions and see if I'm able to answer. Thank you very much.